Hello, everybody. I am Dr. Saili Gore, clinical pharmacist working in the Department of Infectious Diseases at PT Hinduja Hospital, Mumbai. I'm also one of the member of the ID forum of our esteemed FCPI. And I welcome you all to yet again another enlightening presentation of this infectious disease cycle 2. So today we have Dr. Arya Kumar, a distinguished clinical researcher with a strong background in the infection prevention control and antimicrobial stewardship. She has been with Amrita Institute of Medical Sciences and Research Center since 2019, and she's currently leading the ICMR CDC projects on the HAIs. She has also spearheaded projects funded by renowned organizations such as Pfizer and Bill and Melinda Gates Foundation. She has presented as a guest speaker at international conferences. She also extends her interest in curricular development, academic and professional education, IPC building, and research collaborations with national and international institutions. So in today's session, Dr. Arya will give us valuable insights into IV to oral switch of antibiotics, as this topic is now emerging as a new landscape of antibiotic treatment strategies that is especially crucial in managing prolonged infections and maybe making the outpatient care effective and possible. So before I welcome Dr. Arya. Before I hand the mic over, I would like to guide our participants. So participants can you can post your queries or responses in the comment box below and click submit, or you can also email them to the FCPI official. And I encourage all of you to submit your feedbacks below the comment box. And please note that the feedback will be disabled after this session is concluded. And then the certificates for the session will be issued within 14 days after the event and will be emailed to you. And if you're watching this event on the YouTube, please make sure that you log in through the website to claim your certificate. And if you wish to download the slides from the FCPI website, you'll again need to log in the website, and you need to log in just so that you can access the download option. So without any further ado, let's begin today's exciting session. Over to you, Dr. Arya.
Thank you, Saili, for the introduction. Hi, and welcome everyone to today's presentation on IV to oral switch. My name is Arya Iskumar. I'm very excited to share the insights on this important topic, IV to oral switch. In today's session, I will provide a comprehensive overview of IV to oral switch process, which is a crucial aspect of antimicrobial stewardship and patient care. So we will discuss the rationale behind the switch and what are the benefits and the challenges of IV to oral switch and practical guidelines of implementation. So before we begin, I would like to mention that I have no relevant financial relationship with any commercial interest to discuss. Before we dive into the details of IV to oral switch, it is important to outline the key objectives for today's session. So the learning objectives are explain the rationale behind an IV to oral therapy conversion, IV to oral therapy conversion program, differentiate between sequential switch and step-down IV to oral conversion therapy, identify common medication that are included in an IV to oral therapy conversion program, identify patients who are acceptable candidates to convert from IV to oral therapy, describe the exclusion criteria that prohibit a conversion from IV to oral therapy, describe the appropriate steps that involved in performing the IV to oral therapy conversion. So I will detail these objectives. Our first objective is to understand why we consider switching from IV to oral therapy. So we will explore the benefits of this conversion, IV to oral. And we will also discuss how this practice aligns with antimicrobial stewardship goals. And next, we will differentiate between the different types of IV to oral conversion. There are three different types of IV to oral conversion: sequential, switch, and step-down therapies. So understanding these distinctions is crucial for selecting the appropriate conversion strategy that based on the patient's conditions and medication requirements. Then we will identify common medications that can be effectively transitioned from IV to oral forms for implementing this practice. It is very essential to know which medications are suitable for IV to oral conversion. So another important objective is to recognize the criteria for selecting patients who are suitable candidates for this conversion, and we will discuss about the inclusion criteria to ensure that the switch is safe and at the same time it is beneficial for each patient. In the next, we understand the exclusion criteria that may prevent a patient from being suitable for IV to oral conversion. We will explore what are the conditions and scenarios where continuing this IV therapy is necessary. So covering all these objectives, finally, we will outline the practical steps that involved in executing this IV to oral switch. So by the end of this presentation, I hope you will have a thorough understanding of how to implement and manage IV to oral transitions in your practice. So with these objectives in mind, let's move forward and begin our session. The ideal route of administration is one that balance the efficacy and safety. So there are different routes of administrations are available. So different routes can be used that depend on the medication, the patient condition, and the urgency of the treatment. For instance, IV uh, and IV route of administration is often chosen for its rapid onset of action and high bioavailability, especially in mostly in critical situations. So, however, once the patient condition stabilizes, transition to an oral route can offer several advantages because it is generally considered the safest and the most convenient method of drug administration. The next two slides are quite interesting because I have added few myths among the prescribers, so I wait to this oral conversion. So the first myth is bioavailability of IV medication is always higher than that of their oral counterparts, and that using IV medications can produce a prompt symptomatic relief. While it's true that IV medications have 100% bioavailability, but many oral medications also have high bioavailability, sometimes close to that of the IV formulations. For example, antibiotics like fluoroquinolones and linezolid that have excellent oral bioavailability, making their oral forms just as effective as their IV forms for many infections. So as for the symptomatic relief, usually these IV medications do act faster due to direct entry into the bloodstream. So, however, once the initial critical phase is managed, oral medications can maintain its therapeutic level effectively, and the prompt relief that offered by the IV medication does not necessarily translate to better overall outcomes if the patient can be maintained on oral therapy. The second myth is administration of the entire regimen of parenteral antibiotics is more efficacious in preventing relapses during the therapeutic course. So we have clinical data evidences. Many clinical studies have shown that in many infections, once a patient gets stabilized, we start oral antibiotics, and because oral antibiotics just as effective as their IV counterparts in completing the course of treatment. So we have to ensure only that whether we have selected the right oral antibiotic is chosen, or considering factors such as, and also consider the factors such as absorption, bioavailability, and the site of infection. So administering a full course of parenteral antibiotics does not necessarily prevent the relapse better than switching to oral antibiotics. So in fact, this prolonged IV therapy increases the complications like infections at the IV site, like thrombophlebitis, and can lead to higher care cost, and also at the same time longer hospital stay. Let's discuss a common myth that is in the treatment of infectious disease, we need intravenous treatment, and that conversion to oral therapy should be used sparingly. It also implies that oral antimicrobials are not as effective as intravenous therapy. So, coming to this myth, it is essential to understand that many oral antimicrobials are therapeutically equivalent to their IV forms. For example, medications like fluoroquinolones, doxycyclines, and linezolid have high oral bioavailability. So that is often close to 100%, make them effective alternate to IV therapy. And also, in many studies, have shown that for many infections, when the patient is clinically stable and able to tolerate the oral intake, switching to oral antimicrobials does not compromise the efficacy and is equally effective in achieving therapeutic outcomes. So, and also there are clinical guidelines that support the data for IV to oral switch for a range of infections such as urinary tract infection, community acquired pneumonia, skin and soft tissue infections. And so once we have to consider that once a patient meets specific criteria such as improvement in symptoms and ability to tolerate oral intake, we can consider this IV to oral switch. And also, one important factor is that when it comes to safety and convenience, oral therapy reduces the risk that is associated with prolonged IV therapy, such as catheter-related bloodstream infections like eclampsia, thrombophlebitis, and the discomfort that is associated with the IV lines. And it also enhances patient mobility and comfort that contributing to better overall patient satisfaction. So, and additionally, when it comes to oral therapy, it can be administered in OP settings also, and which can significantly reduce healthcare costs and the need for prolonged hospital stay. So when considering this switch from IV to oral therapy, it is crucial to evaluate patients' clinical status, the bioavailability of the oral medication, and the site of infection. So as a clinical pharmacist, we can have a effective communication and collaboration among these healthcare providers. That is very essential to ensure a smooth and safe transition. So you may experience in your practice when you try to do an intervention in IV to oral conversion. Some prescribers may be hesitant to switch due to concerns about the efficacy of oral therapy. So in that cases, it is very important to rely on current evidence-based guidelines and protocols which provide a clear criteria for this safe conversion from IV to oral therapy. We always approach them with a clinical data support. So other two myths associated with this therapy means IV to oral conversion therapy are Medicare will not reimburse for the care of inpatients on oral therapy. The oral antimicrobial must be the same medications or from the same medication class as the intravenous agent. So this not necessarily true. While if it's often convenient to use the same medication class for the continuity, it is not a requirement. So only make sure that this oral agent has similar efficacy, spectrum of activity, and bioavailability to treat the infection effectively. So, for example, a patient on IV ceftriaxone for a respiratory tract infection could be considered to oral cefuroxime or another appropriate oral agent that covers the same pathogens effectively. So, why this IV to oral switch is needed? Because of the increased length of hospital stay, increased cost of nursing, pharmacy, and the medical time in the insertion of IV lines, preparation, and the dispensing and administration of these IV agents, and it increased the morbidity and mortality that have been associated with IV line infections like CLAPSI, catheter-related bloodstream infections. So the advantages of oral over IV route. So switching to oral therapy that allow for a quicker removal of these IV catheters that significantly reduce the risk of CLAPSI, that is central associated bloodstream infections. This not only enhances patient safety by lowering infection risks, but also improves patient comfort and mobility. So another advantage of oral over IV route are it's hospital discharge, reduce the length of stay, and reduce the volume of fluid administered to patient. That can be especially important for patients with congestive heart failure and increase patient satisfaction and comfort, reduce IV-related mobility restrictions, and remove the possibility of phlebitis or thrombophlebitis, that reduce the workload on pharmacy and nursing. So, what are the disadvantages? Then any process that has advantages and disadvantages like that, it also has disadvantages when switching from IV to oral. So the disadvantages of IV oral, disadvantages of oral over IV route are then switching to oral therapy make it's more challenging to ensure that the patients are consistently taking their medications as prescribed in a hospital setting. Because the administration is controlled by healthcare professionals. So we can monitor them, the adherence to the IV therapy is more easier. So when comes to IV therapy, the second disadvantage is when it comes to IV therapy, it provides an immediate access for the rapid administration of medications or fluids in emergency situation. So with oral therapy, which can be critical in emergency where immediate intervention is required, and also the potential for less clinical efficacy depending on the disease state. So moving to the types of IV to oral conversion, there are three conversions are available: sequential conversion, switch conversion, and step-down conversion. So in sequential therapy, it involves replacing this intravenous parenteral form of a medication with its oral counterpart that contain the same active compound. In sequential therapy, replacing this IV form of medication to oral form that contain the same compound. Because we are changing with same class of drug. Okay. And in switch therapy, it refers to the conversion of IV to oral equivalent with the same drug class and with equivalent potency but different chemical compound. In switch therapy, we are changing with to an oral agent with same drug class and with equivalent potency but with different chemical compound. And the last is step-down therapy. In step-down therapy, that involves transitioning a patient from an injectable medication to an oral agent, either within a different class or to a different medication with the same class, with the potential differences in frequency, dose, and spectrum of activity. Here, we convert to a oral agent of different drug class or to a different medication with the same class, but the difference is with the potential difference in frequency, dose, and the spectrum of activity. So here are some of the examples of conversions. So in sequential therapy, injection pan to tab pan, injection famotidine to tab famotidine, injection levofloxacin to tab levofloxacin. In switch therapy, same class but different drug. Injection ceftriaxone to tab cefixime, injection pantoprazole to tab rabeprazole or omeprazole, injection levofloxacin to tab ciprofloxacin. And the examples of step-down therapies: injection cefotaxime to tab ciprofloxacin, injection heparin to tab warfarin, injection ampicillin sulbactam to oral amoxicillin clavulanate. So in this slide, we'll discuss what are the medications that are included in an IV to oral conversion program. So under sequential to switch therapy, azithromycin, ciprofloxacin, levofloxacin, linezolid, metronidazole, and moxifloxacin that are more frequently targeted for IV to oral conversion program, and less frequently targeted are cefuroxime, clindamycin, doxycycline, and sulfamethoxazole trimethoprim. So under step-down therapy, ampicillin and ampicillin sulbactam, piperacillin tazobactam, piperacillin clavulanic acid, aztreonam, cefazolin, cefotaxime, or ceftriaxone, or cefuroxime, or cefodime, or ceftazidime, or cefepime. So antifungals like fluconazole, they are frequently considered for IV to oral conversion, and less frequently considered itraconazole and voriconazole. And for step-down therapy, some institution will initiate therapy for amphotericin products and echinocandins. So antivirals like aceclopir and ganciclovir, and gastrointestinal agents like famotidine, cimetidine, ranitidine, esomeprazole, and suprazole, and pantoprazole, they are frequently considered for this IV to oral conversion. And then cardiovascular agents like digoxin, diltiazem, enalapril, metoprolol, and neurological agents like phenytoin, levetiracetam, phosphonatoin. And endocrine agents like steroids like dexamethasone, hydrocortisone, methylprednisolone, and levothyroxine, and other agents like ketorolac and warfarin. They are considered for sequential to switch IV to oral conversion. So for considering antibiotics in step-down therapy, you should be confirmed based upon the culture and the sensitivity report. And this list is not all inclusive. So then comes a question to your mind that when to switch. So we have to review for oral switch only after 2 to 3 days of IV conversion. So as a clinical pharmacist, what are the practical approaches we can do for the conversion of a patient from IV to oral therapy? So first, should identify the patient who receive IV medications and recognize the need for IV medication in those patients and check for the indication. And next, we have to regularly follow up this patient, and regular follow-up is needed to check whether the patient clinical status like WBC, vitals, culture report, patient physical and mental condition is improving or not, or if the patient is febrile, and if we found to have that the patient is eligible for conversion, we apply the inclusion or exclusion criteria and check whether the conversion was done. So inform the physician about the patients who are eligible for conversion but are not converted within the appropriate time, and make suitable recommendation for the selection of oral to IV conversion. And we have to review the feedback of the physician after this conversion, and monitor the patient clinical progress after the switch over, and convert the patients back to parenteral medication if it is required. So, and it is also advisable and it is very important to verify the knowledge and the beliefs of physicians regarding this guideline for IV to oral switch. And for this, we can have a data collection. 2 oral questionnaires can be used for the same. So, moving to what are the ideal characteristics of an antibiotic employed by an IV to oral switch. First, main important factor is that we have an clinical data to support our intervention in hand. So next is the excellent bioavailability. Next is the infrequent dosing schedule, and there is no significant food drug interaction or drug interaction with the selected oral antibiotic. Few adverse events when taken orally, or easy to storage, or easy to swallow spill, and also inexpensive. So coming to the selection criteria. So what are the patient's selection criteria we consider for IV to oral switch over therapy? So the inclusion criteria include a patient who is able to eat their regular or modified diet, or they are receiving enteral nutrition by oral, gastric or other appropriate enteral route. So, and also the patient who receive other scheduled oral medications. For who receive antibiotics, antibiotics, and also the signs and symptoms of infections resolved or improving, and the patient became febrile, and the patient has functioning gastrointestinal tract, and also the most important inclusion criteria is in an appropriate oral dosage form of prescribed drug is available, and also the absorption and the availability of the selected oral counterpart is almost comparable to that of the parenteral form. So coming to the exclusion criteria, patients with severe nausea or vomiting, the patient who are unable to swallow or unconscious, the patient who are under strict NPO for a procedure, obstruction, malabsorption, active bleeding, and the patient who are responsive to previous oral therapy, or patient with grade 3 or 4 mucositis, and patient in some disease conditions like meningitis, infective endocarditis, infection of a prosthetic device, osteomyelitis, sepsis, severe cellulitis, bronchitis, pneumonia with AIDS. In that cases, we consider IV regimen over this oral therapy, because these are disease state that do not support oral therapy. And also patient who have seizure and a risk of aspiration, patient with hypotension or hypovolemic shock, or the patient who refuses an oral medication as mentioned in the chart. And with and the last exclusion criteria is that immunocompromised patients with febrile neutropenic patients, or chemotherapeutic patients, or post-transplant patients. So the factors to screen for prior to changing from IV to oral antibiotics. First, we have to check the infection type. So whether the IV oral IV antibiotic has to be continued or not. So we have to check. Next, we have to check the duration of IV antibiotics received to date. So commonly after 2 to 3 days IV before switching to oral, to allow for more clinical data to become available and for patient to show the clinical improvement. So, and also for check for the stabilized vital signs like heart rate, respiratory rate, and stable blood pressure and mean arterial pressure. And check for patient temperature, and also the WC count, and check whether the patient is improving symptomatically and the patient mental status is improving, and check whether the patient have any allergies or not. And we have to also check whether the patient medication profile, and you have to check the drug interactions and drug food interactions. And the lab findings include a renal function test and hepatic function test. And also we have to check whether the patient is able to swallow or receive enteral feeding. So we have to check, sorry, eating, this patient is eating food or drinking fluids or tolerating other oral medications, receiving parenteral nutritions, um, and also the sensitivity of profile of these infecting organisms. And most importantly, we have supporting data for using these oral antibiotics to treat the given infection type and organism. So the criteria that is used to determine whether or not the patient is eligible for oral therapy may vary from hospital to hospital. So we check for the functioning GI tract, improving clinical status, does not meet any exclusion criteria. Other factors that influence absorption include gastrointestinal pH, surface area, and permeability, blood flow to the GI tract, and patient displaying signs and symptoms of shock. So criteria, what are the criteria that indicating absorption of oral medication may be compromised? First is if the patient is in NBO status, or the patient have NG2 with continuous session is ongoing, and patient with severe or persistent nausea or vomiting. In some patient with gastrointestinal transit time is too short for absorption for malabsorption syndrome patients, or partial or total removal of the stomach, or short bowel syndrome cases. So, and also the active gastrointestinal bleeding, and check whether the patient is on a high dose of vasopressor medications, and the patient have any difficulty in swallowing or loss of consciousness and no access available, and whether there is any documentation of ileus or gastrointestinal obstruction. And we have to check whether the patient is on continuous tube feedings that cannot be interrupted, and patient requires medication not to bind to enteral. So moving to the conversion from IV to oral therapy in the presence of a continuous tube feeding, uh, select the most appropriate oral formulation of the medication for NG tube administration. So most preferably, we consider solution or suspension over the tablets. And in order to avoid the blockage, we have to flush it with these feeding tubes with water before and after the medication administration. And we consider only medications which are compatible with tube feeding, and stop the feeding and administer the medication. For example, suppose if the patient is on NG feed, then we have to administer oral fluid. We have to change to oral fluid or pills. First, we have to stop the tube feedings for at least 2 hours before and 2 hours after administration. Second example is for in case of phenytoin, which is dosed more than once a day. So, tube feeding can be stopped approximately 1 hour before and 1 hour after medication administration. So, always consider this in mind, that medication should never be added directly into the tube feedings. So suppose if the patient clinical status is improving, so some patients may be clinically improving but have leukocytosis due to steroid therapy. In these cases, if the patient meets all other criteria, a safe conversion of IV to oral can be still be made, can be considered. Okay, and also review the cultured pathogen and whether the patient have any GI bleed or not. So moving to the factors that may prevent changing from IV to oral antibiotics. First is necessary medication that are not available in the means in an oral formulation. Clinical instability, active order for no medication by mouth because the patient is in NBO status, ongoing nausea or vomiting, significant aspiration risk, abnormal gastrointestinal abnormal gastrointestinal transit time, malabsorption syndrome, gastrointestinal obstructions. continuous gastric suctioning, continuous 2 feeds that cannot be interrupted, and patient actively receive a high dose vasopressors, and oral antibiotics that is not favorable for antibiotic indications for potential examples like bloodstream infection, infective endocarditis, meningitis, brain abscess, acute osteomyelitis, necrotizing fasciitis, febrile neutropenia, or orbital cellulitis. And also lack of functioning immune system interfering with the assessment of clinical improvement. So coming to the general pharmacokinetics and pharmacodynamic issues. So when choosing an oral medication, it is very important to consider its effectiveness, its ease of use, and how well it is absorbed by the body. The medication should be easy for the patient to take with minimal side effects or inconvenience. So coming to the bioavailability, which indicates how much these medications actually gets into the bloodstream, is crucial. And while IV medications have 100% bioavailability, so that is not always case for oral or other routes of administration. These oral antibiotics in particular need to be as effective as their IV counterparts in fighting the infections. So this table the examples of drugs with excellent bioavailability, that is greater than 90% eligible for IV to oral switch. Samples are ciprofloxacin, doxycycline, esomeprazole, fluconazole hydrocortisone, and ketorolac. Levetiracetam, levofloxacin, ilosolid, metronidazole, minocycline, moxifloxacin, phenytoin, rifampicin, and voriconazole. So examples of drug with good bioavailability, that is 60 to 90% eligible for IV to oral switch are ampicillin, azithromycin, cefazolin, cefotaxime, ceftazidime, cimetidine, cefuroxime, clindamycin, digoxin, erythromycin, pantoprazole. Then coming to the application level of IV to oral switch. So the therapeutical applications, we are focusing especially on some common disease conditions like in community acquired pneumonia. So in the treatment of this community acquired pneumonia, approximately 40 to 60% of patients can be switched from IV to oral therapy within 2 to 3 days, provided their vital signs and WBC count are stable. So fluoroquinolones are often considered the preferred choice for this switch. And there are studies that comparing IV to oral moxifloxacin with IV to oral amoxicillin clavulanate with or without clarithromycin. Have shown that moxifloxacin leads to a higher percentage of clinical cure. So this switch help in reducing the length of hospital stay and the risk of complication that is associated with the IV therapy. Sorry. So coming to the first case of this session, a 52-year-old female admitted to the general ward of a hospital with cough and breathing difficulty was treated empirically with injection cefoperazone sulfabactam 2 gram BD and tab levofloxacin 500 mg OD. She was started on injection pantoprazole 40 mg BD and injection neurobion fort. Her vitals and WBC counts become normal from the 3rd day of submission. Later, her sputum culture showed growth of Candida albicans. She was then started on tab fluoroquinolones 100 mg BD for 10 days and injection cefoperazone sulfabactam was stopped, but tab levofloxacin was continued till discharge. So this case illustrates an to oral conversion done at the appropriate time, because all the other parenteral medications were switched over to oral form from the 3rd day of admission. Injection pan to tab pantoprazole and injection neurobion to tab neurobion forward, and the patient condition is improved within the oral medications. So another application is in infectious diarrhea or a typhoid enduric fever. So in cases of this acute watery diarrhea that is caused by pathogens like E. coli, Campylobacter, sorry, Salmonella or Vibrio species, these quinolones are the preferred therapy, whether administered intravenously or orally for a duration of IDs. So both forms have the same bioavailability, making the switch from IV to oral therapy that is feasible once the patient condition stabilizes, and that potentially allowing for OP management and reduce the need for hospitalization. So moving to this case 2 of this session, a 22-year-old male admitted for acute gastroenteritis was started on ciprofloxacin 200 mg IV-BD and metronidazole 500 mg IV-TID. He was also started on the day injection band 40 BD and tabracicodatal 100 mg TID and paracetamol. So from the second day, his diarrhea and vomiting subsided and was able to take oral food. His vitals become normal on the third day of admission, and the WBC count was 9,730. So, is it possible to switch over the IV medications of this patient to equivalent oral form at the earliest? Yes, we can switch from IV to oral once the patient's condition is stable and whether the patient can tolerate the oral medications. So moving to the exclusion criteria for considering antibiotics in IV to oral conversion are in deep-seated infections like abscess or empyema, Staphylococcus aureus infection in bacteremia, meningitis or encephalitis, osteomyelitis, necrotizing soft tissue infection or septic arthritis, infective enterocarditis, and also with patients with multiple antibiotic allergies may be restricted to therapy choice that may only be available parenterally. And with patients who are at a risk for this active seizure or who are unable to tolerate oral medication without the risk of aspiration, they are not appropriate for considering to IV to oral therapy. So when considering the cardiovascular agents, patient with unstable cardiac conditions or for whom frequent dose changes are occurring, through IV drip titration, they are not considered good candidates for IV to oral therapy. Sorry, excuse me. So coming to the specific medication class consideration, first we discuss about the fluoroquinolones. So fluoroquinolones like ciprofloxacin, moxifloxacin, levofloxacin, they are mostly involved in almost in all hospitals in the IV to oral therapy conversion program. So because these are ideal for conversion because of their high bioavailability, rapid absorption, and total distribution within the body. So these one thing we have to take into consider in my counseling point, the fluoroquinolones absorption may be affected by the concurrent administration of these products that containing calcium or calcium containing antacids like iron, zinc, salt, or as well as medications like sucralfate, where fluoroquinolones has interactions with this calcium or calcium containing antacids, iron or zinc salt, or medications like sucralfate. Taking that into consideration. Example, ciprofloxacin should be given 2 hours before or 2 hours after these products, according to the criteria. Then the levofloxacin can be administered 2 hours before or 2 hours after these medication, and moxifloxacin should be considered 4 hours before or 8 hours after these products. And ciprofloxacin, when coming to the ciprofloxacin suspension, that should not be administered by a feeding tube because due to this physical characteristics, and all quinolones can be taken without regarding to males. So the special consideration under triazole antifungals like fluconazole, itraconazole, voriconazole, and posaconazole. Like this fluconazole is well absorbed in most patient types, and it is not affected by food or alteration in gastric pH. So there are several studies that conducted in surgical patients with compromised gastrointestinal absorption who have had fluconazole with availability to be 100%. And among the triazoles, itraconazole is unique because it requires an acidic gastric pH for the absorption. So, and also we have to check the drug interactions of with antacids, H2 receptor antagonists, and proton pump inhibitors because it reduces the absorption of itraconazole when giving both together. So, and also check whether the patient is on sucralfate because it may also affect the itraconazole absorption. And the solution is better absorbed on an empty stomach while the capsule should be administered with the but on the other hand, this voriconazole, it is better administered 1 hour prior or 1 hour after meals. So both this itraconazole and voriconazole IV formulation that is contraindicated in renal dysfunction patients because of this potential accumulation of cyclodextrin from the solution that will lead to renal toxicity. So coming to the general consideration, when considering vancomycin, we know it is one of the few medication where the oral and IV formulation have different uses. So this IV formulation is used to treat usually positive bacterial infections. And however, this oral formulation, we know it is poorly absorbed and it is typically only used in the treatment of this Clostridium difficile colitis. And other antibiotics are linezolid, for example, linezolid. It's we know it is unique and because it's weak and it's a non-selective reversible inhibitor of monoamine oxidase. And patient receiving these drugs should not consume foods or beverages that is high in thiamine because it can lead to severe hypertensive reaction because it can place them at a risk for serotonin syndrome type reaction. So the consideration for H2 receptor antagonist and proton pump inhibitors in IV to oral conversions are because of their mechanism of the action of this proton pump inhibitors, they're most effective when administered on an empty stomach, usually or at least 30 minutes or 1 hour prior to meal. And also think that consider that you have to mix in solution prior to the administration through a feeding. Suppose if the patient have a feeding tube, have to administer oral PPAs, then we have to mix that in solution prior to the administration. And usually some of the PPAs are enteric-coated granules. So, and also take into consider that it is important not to crush or chew these granules and to dissolve them only in acidic substances to keep the enteric coating intact. So next slide, I'm discussing about the protocol or the pathway for IV to oral switch. This protocol is called STOP protocol. And in STOP protocol, we first look into the signs of clinical improvement. If patient is showing clinical improvement, signs of clinical improvement, then we have to check whether the patient is tolerating oral medicines. If the patient is not showing any clinical improvement, any signs of clinical improvement, then we review the therapy and investigation, and we consult the ID or micro if necessary. And if suppose the patient is tolerating oral medication, then we have to check whether there is any oral option is available. If the patient is tolerating orally, then we go for whether the patient whether any oral option is available. If it is not tolerating to oral medication, we reconsider the switching 24 hours. So if the oral option is available, then we check for the possibility to switch because in some cases, prolonged parenteral therapy is required for the following indications like deep-seated infections, necrotic fasciitis, meningitis, encephalitis, endocarditis. So in that case, if oral option is not available, or if it is not possible to switch, we continue the IV treatment course and we contact the ID physicians or clinical microbiologists if necessary. So suppose if it is possible to switch from IV to oral, then we check is this antibiotic therapy is still required or not. If it is still required, then we switch to IV to oral. Then if it is not required, we stop the antibiotics. So we can use this template for the decision of IV to oral switch. So we can move to the case scenarios related to IV to oral switch. The case 3 of this session is a 72-year-old female admitted for urosepsis. Vital signs on admission: patient is hypotensive, heart rate is 90, and patient is febrile, and WBC count of 9,000. And she was started on ciprofloxacin 400 mg BD, famotidine 20 mg IV BD, and other IV fluids. And she was taking an oral blood pressure medication prior to admission, but this was held secondary to the hypotension. And the nurse also noted in the chart that the patient was nauseous and has not been able to tolerate anything orally. So, going to the first question. Which of the following conversion example demonstrate the concept of IV to oral sequential therapy? So option A, ciprofloxacin 400 mg IV BD to ciprofloxacin 500 mg BD. Option B is famotidine 20 mg BD to ranitidine 50 mg IV TID. Option C, aztreonam 1 gram IV TID to ciprofloxacin 500 mg BD. Option D, famotidine 20 mg oral BD to famotidine 20 mg IV BD. So our question is, which example demonstrate the concept of IV to oral sequential therapy? We know this. We have already discussed about what is sequential therapy. What factors we considered before considering this sequential therapy? We converting to same compound of oral form of same compound. The correct answer is ciprofloxacin 400 mg IV BD to ciprofloxacin 500 mg oral BD. So next question, IV dose of famotidine is higher than oral dose of famotidine on a milligram per milligram basis, and a dose reduction should be made when converting to oral therapy. Is it true or false? It's true, because this IV dose is usually higher than that of the oral dose of famotidine. Question 3. Which of the following excludes this patient from receiving oral therapy on admission? Option A, patient blood pressure medication is held, patient is hypertensive, patient is nauseous and not tolerating anything orally, all of the above. In this question, we is asking which of the following that exclude this particular patient from receiving oral therapy on admission, because we already mentioned in the case that the nurse already noted that the patient is nauseous and is not tolerating anything orally. So the correct answer is patient is nauseous and not tolerating anything orally. So the case 3 is continuing. After 3 days of treatment, the patient appears to be improving clinically. Her oral blood pressure medication has been restarted, and the rate of IV fluid decreased. Her nausea has subsided, and she is eating about 50% of her meals. Her WBC count is 6,500 and it is reduced from 9,000, and her temperature is 98.7 Fahrenheit. So, coming to the question 4, which of the following must be present for an appropriate IV to oral therapy interchange? Option A, an oral medication with poor bioavailability, able to tolerate oral intake, presence of severe infection such as endocarditis or osteomyelitis, clinical stability. So the correct answer to this question is whether the patient is able to tolerate oral intake. Question 5. Which factors make this patient eligible to tolerate IV to oral therapy conversion? So patient is taking critical oral medication by mouth. Option A, patient is taking critical oral medication by mouth. patient is eating 50% of their meals, WBC count trending downward, and febrile, all of the above. So the question is, what factors make this particular patient that is eligible to tolerate IV to oral therapy conversion? Because in the scenario we had this, is already mentioned that the patient is her or she's continuing her oral blood pressure medication. He's restarted, and she's eating about 80% of her meals, and her WBC count is decreased. So the correct answer is all of the above. Moving to the case 4 of this session, a 62-year-old male patient who presented to the hospital with complaints that have coughing, blood. This patient has a lengthy history of alcohol abuse and has been admitted several times before. He is placed on NPO status and undergoes an endoscopy evaluation, which reveals active GI bleeding. The gastroenterologist orders lansoprazole IV. Overall, looks to be in relatively stable condition, with the exception of a lower blood pressure and a temperature of 100.2 degree Fahrenheit. Pertinent and past medical history indicates he was diagnosed in a physician's office 8 days prior to admission with bronchitis, for which he was given a full course of azithromycin. So, going to the question 6, why he is not a candidate for oral therapy at this time? Option A, temperature is elevated to 100.2 degree Fahrenheit, active GI bleeding, recent diagnosis for bronchitis, Medicaid will not pay for the hospital stay. So the correct option is active GI bleeding. So question 7, moving to the question 7. The only reason to perform IV to oral therapy conversion is to reduce pharmacy expenditure. Is it true or false? It is false, because it is not the only reason to perform IV to oral therapy conversion. Moving to the case 5. An 18-year-old male who is brought to the emergency department and is actively have seizure. He has no significant past medication history. However, his mother reports that he recently developed severe headaches and have a high fever that started within the last 24 hours. So initial medications ordered include fosphenytoin, ceftriaxone, vancomycin, and dexamethasone, all given by the IV route. A lumbar puncture is performed and the result written, and the patient is diagnosed with bacterial meningitis, and he is admitted to the ICU, where he is intubated and started on mechanical ventilation. Several days later, an NG tube is placed and he started on tube feedings. So moving to the question 8. Which of the following medication should not be converted to oral therapy due to a difference in therapeutic activity when given orally? Option A, vancomycin. Option B, dexamethasone. Option C, ceftriaxone. Option D, fosphenytoin. So we already discussed in our previous slides that consider oral vancomycin only in case of in the treatment of Clostridium difficile infection. So the correct answer is vancomycin. Question 9. Which of the following medication in its equivalent oral form is most likely to interact with the two feedings if administered concurrently? Then option A, vancomycin, dexamethasone, ceftriaxone, and fosphenytoin. Option is fosphenytoin. Question 10. Which of the following statement is true based on his clinical presentation? The patient cannot receive oral medication because he is on ventilator. The antibiotics should, option B, the antibiotics should continue to be administered intravenously to the diagnosis of meningitis. If converted to, option C, if converted to oral phenytoin, the two feedings would have to be held for 6 hours before and 6 hours after administration of the medication. The patient can be converted from IV vancomycin to oral linezolid. So the correct statement based on this clinical presentation is the antibiotics should continue to be administered intravenously due to the diagnosis of meningitis, because we already discussed in some medical conditions, in some disease state, we consider IV therapy or over this or. So, what are the pharmacoeconomic benefits of IV to oral therapy conversion? So, by changing the route of administration from intravenous to oral, result in direct cost reduction, that are medication cost, supply cost, and also the personal time spent for the preparation and this administration of doses, that is greatly reduced. And there are several studies that document the direct impact of this aggressive and early IV to oral therapy conversion program. So, in one study that specifically focused on levofloxacin, found proactive conversion to oral formulation that reduced the length of stay and the saved medication and supply cost and total hospital cost for each patient. And in one study that documented the early conversion from IV to oral therapy in patients with community-acquired pneumonia, that decreased length of stay by almost 2 days with no further negative effects or mortality or clinical cure. So, coming to the summary of this session and what are the take-home messages. Well, consider only thing that IV to oral therapy conversion that represents a cost effective strategy. As a clinical pharmacist, we have the opportunity to reduce unnecessary medication cost. This improving the therapy and improving the patient safety and comfort. So, and we have to select appropriate oral medication use that will produce equivalent clinical outcomes, causes fewer complications related to IV lines, less patient inconvenience, and it's generally less costly. And also consider that the patient who are eligible to IV to oral conversion are the patient who are tolerate oral medication, the patient to be converted to an oral agent that acts similarly or equivalent to the IV counterpart, that meet the inclusion criteria or not have any contradiction to oral therapy and be improving clinically. So in the coming slide, I have added a few data, this article's data, discussing about the data for the consideration of administration by feeding tube. We can go through these articles. In this article, they're discussing about the data for the serious infections. In this article, they're discussing about the data for bone and joint infection. And here are the data for osteomyelitis, bacteremia, Staphylococcus aureus, bacteremia. And here in this article, we have data for Staphylococcus aureus, bacteremia. And in this article, they are discussed about the data for bloodstream infection and the data for both gram-positive and gram-negative, and for the candidemia, for endocarditis, and the data for intra-abdominal infection. You can refer these pages or these articles for more details. And the data for complicated urinary tract infection. And article, they are discussing about the complex outpatient antimicrobial therapy. So the reference I have added, these are the references I have used for the preparation of this presentation. Thank you. I hope all are. So if you have any questions, you can reach us at our mail ID, fcpaofficial@gmail.com. Thank you.
Thank you, Dr. Arya. It was a very, very informative and amazing session. You've covered almost all the points regarding this IV to oral switch and shedding light to this critical aspect of the oral regimen. And you also explained about what it is and which scenarios it should start, how you should give, and what is mainly what is the clinical pharmacist role in this, and even explain the PKPD parameters. So it was an amazing session. So I think I just have one or two questions for you, posed for you for just for the audience. We would just like to know if the clinicians at your hospital are like following this, or are they really convinced, well convinced by for switching the IV to oral?
Actually, in our hospital, most clinicians generally follow the recommended formulations for IV to oral switch, and they are almost convinced of its efficacy. So we always approach them with this evidence-based practice, and we have clear data for supporting clinical data for supporting that our interventions. So they understand the benefits. They now understand the benefits such as reduced hospital day. This IV to oral conversion reduces the hospital stay, and it lower the cost, and it decrease the risk of these IV related infections like thrombophlebitis, or catheter related bloodstream infection, and thus prolong the hospital stay, and thus increasing the cost of care.
And another question for you is like, as a clinical pharmacist, what is your take on the medications, antibiotics that are given to the adult patients who are clinically stable, hemodynamically stable, but for just and even having normal GI functions, but for some reason they have RT, especially if they are seizure, or they are having risk of seizure or risk of any aspiration. So what is your take on crushing the antibiotics and giving them with dissolving in water and administering through RT? I'm not asking about feeds because I know usually we're supposed to give it feeds, but if what is your take on dissolving in water and giving?
Actually, we have to check whether in the clinical guidelines that follow that discussing about this crushing these tablets, because I'm not a person to clearly answer this question, because it's very I can't say we can crush these medicines in solutions or in water or not. So we have to check whether the clinical data that supports this statement. So before we approach the clinicians about this administration of this means antibiotics over the patient who are on injured too.
Okay. I think that's all. Thank you so much for this session. Your expertise in this topic has truly been very comprehensive, and I love all your slides. So I guess let's conclude this session for today. And if all the participants, thank you all for your participation. And if you have any queries, please write us on fcpi official@gmail.com. And have a great evening, all of you. Thank you, Arya.
Thank you, sir.